very hearty welcome to everyone and good evening to all who have joined for this panel discussion and all the guest speakers. The theme of this panel discussion is the Leprosy Control Project. This is an initiative by VOH in association with Rotary Club of Delhi South and partner Rotary Clubs, LEPRA and ACRE. We have a very eminent set of panelists with us whom I'd just like to introduce. First of all, we have Dr. Ritu Chaudhary with us. Ma'am is State Leprosy Officer at Delhi State Health Mission. We have Mr. Mohammed Shariq with us. He is Head Corporate Social Responsibility at ACRE. Mr. Deepak Kapur, he is Head Rotary Club Alliance for Leprosy Control. Welcome, sir. We have Mr. Prasant Naik. He is CEO at Lepra Society. And we have Dr. Shubnum Singh with us. Ma'am is Principal Advisor Health at Confederation of Indian Industry, CII. And also, while sharing her expert views, ma'am will also be leading this conversation. So, without any further ado, I'll hand it over to ma'am. Ma'am, over to you. We can have our rounds of questions. Thank you.
Thank you. Thank you, Khushbu. And a very warm welcome to all the panelists. I must compliment Voice of Healthcare. They have this ability as well as capacity and focus to bring about things that we forget but are so very important. And I think leprosy falls into this particular bucket. We've moved on, and from time to time, as we move, our lives are overtaken either by NCTs, non-communicable diseases, or we walk into areas, unfortunately, like COVID. Somewhere along the line, hepatitis also comes, and things which are as old as AIDS, if I may say so, leprosy, are forgotten and left by the wayside. The unfortunate truth is that despite having a national leprosy eradication program, we still in India stand at being number one as far as the number of leprosy patients are concerned in value terms. There are pockets where the prevalence or the incidence of this disease has gone down drastically. And yet there are pockets where it is concentrated, Chhattisgarh being one of them. So the question, I think, and the conversation that we intend having now is to step back a bit, review what has happened so far. What is it that we have done which has at least brought us to this point of bringing down the rates in some areas while others have not? And what is it that we need to do to ensure that we come to a point where it is totally eradicated? Needless to say to everybody, leprosy, unfortunately, for centuries carries with it a stigmatization where anybody who has leprosy is a social pariah. You don't want to talk about it, you don't want to get investigated, you don't want to tell anybody you're having treatment about it. And thereby, just because it's a very slow moving infection, where the incubation period is so long that by the time it comes as a differential diagnosis, it comes to a point where you are tottering for it to have a multi-drug resistant situation. So these are some of the challenges, but I'll stop here and move to our panel who are far better equipped and knowledgeable in this field. And then the first round, I'll walk with you as to what is the status just now in your opinion. And in the second round, if you could share what are the solutions or what are the to-do bits to help us move forward. We should not end up being in a situation of Brownian movement where we're just circling or jogging at the same place at the same time next year. So I'll move to Dr. Ritu Chaudhary first, State Leprosy Officer of Delhi. So, ma'am, what is the current, how many leprosy patients currently reside in Delhi? And when you're working with them, what are the misconceptions that they have about the transmission of this disease or the concept of this disease? Over to you, Dr. Ritu.
Yeah, thank you, ma'am. If we talk about leprosy, leprosy is a disease. It's a bacterial disease caused by Mycobacterium leprae. And if we talk about the leprosy case, there are two type of cases. One is the active case of leprosy. Another is people affected by leprosy. So, active case of a leprosy is a person who is having signs and symptoms of leprosy, but yet to complete the treatment of leprosy. And a leprosy affected person is a person who have completed their treatment, but they're living with the complications of leprosy, like clawing of hand, wrist drop, ulcers, disabilities and deformities. So if we're talking about active cases of leprosy, right now in Delhi we have around 1477 cases on treatment, and out of which 743 registered since 1st April 2021. So, active cases are around 1477. And your second question was regarding the misconceptions about the transmission of disease. Usually, people think that this disease is very contagious. But in the fact is, 95% of the population is not susceptible to this disease, and only 5% can catch this infection. And regarding the mode of transmission, usually people think if we will catch the infection just by a contact, by shaking hands, or by sitting next to the patient, or by talking to someone. So this is not the scene. Actually, the disease is transmitted through droplet, that is the respiratory tract, and the portal of entry and exit is the nose. So it is spreads through the droplets, not by contact.
Thank you. So when you mentioned that 97% of people are not susceptible, it begs the question, what predetermines that susceptibility? Or is there
It is
something?
the immunity. Sorry, please
Yeah,
go
please
ahead.
go ahead.
It depends upon the immunity status of the person. Like 85% are not susceptible to the disease, and the rest 15%, even if they acquire the infection, it heals itself. I'm mentioning this. The 95% of the cases are not susceptible. It depends upon the immunity status of the case of the person.
Fine. So if you're immunocompromised or something, then this automatic resolution of 80%, you don't fall into that bucket. That's
Yes,
exactly
yes.
what you're saying. Okay, great. Uh, so I'll move to Mr. Muhammad Shariq, Head Corporate Social Responsibility, ACRE. Uh, why do you, what is the role of CSR, or in your role as head of CSR? How many companies, or what is the sensitization of companies in general about leprosy? So you hear a lot about people giving money for tuberculosis, uh, for HIV, for COVID, etc. What in your experience has been the kind of commitment towards leprosy?
Good evening, everyone. You know, as a CSR partner of this project, we always feel proud to be associated with it in the sense, when initially last year, when we were talking to the Rotary Club for this, to launch this project, and the entire project, it's not a small project, it's a long-term project wherein, we have been told that it will be running into 10 to 12 years. And the pilot project, and we are running the pilot project only in Delhi and NCR as of now. Now, with regard to the CSR role as a corporate entity, since everybody is aware, post 2013, it has become mandatory for a lot of organizations to, contribute towards the CSR activity. And I'm very pretty sure that most of the organizations are looking for the projects wherein actually they can bring an impact to the society. And majorly, as far as I understand, a lot of institutions wants to contribute towards the healthcare sector, wherein we feel that there is a lot of projects can be run which can really bring an impact to the society, because we completely cannot depend upon the government in the sector. uh, in healthcare, as if I speak about on behalf of Acre, we have identified only three areas wherein we are contributing for last 7 8 years, and that is in the sector of education, healthcare, and skill development. But our major contribution is coming towards healthcare only, and we have been doing other parallel projects also. But as you, ma'am, rightly mentioned, the people are more towards HIV, towards heart diseases and other diseases. But leprosy was a new thing, wherein when we were told, this is a project which is going to be pan out across the country, and when we came to know, to be very candid, even myself was not very much familiar with the leprosy when we start this project, and we were not sure. Like how much people are affected by it. The common myth which is still there in the society is, yeah, that this cannot be treatable. There are a lot of things, as Ritu ma'am has already spoken, that there's a lot of social stigma attached to this entire disease. So we were also concerned. We thought, okay, how can it be such an important disease where only few number of people were affected by it? But when we get into detail into of this entire project, we realize that this is something we should kickstart. And after contributing to this project, we are very pretty satisfied since last year, because there are a lot of areas which are covered in under this project, and which I will tell you in the during the conversation also. So I think everybody has a role to play herein. A lot of CSR contributions should come in here, and government, private, public sector, civil society, everybody has a role to play to achieve the common objective of eradicating the entire leprosy disease from the society.
Yes. Dr.
Ma'am, you're
Shubnum,
mute.
you are muted.
Right. Yeah, so you're bringing out that you're reiterating that point that somehow it hasn't got the eyeballs of people, and it doesn't resonate, or people have forgotten about it, or they find it convenient because of social reasons not to look at it. And therefore, it's very important to bring it back into discussion for people. And today, as everybody knows, for every company, ESG is exceedingly important, and therefore commitment to funds for this should work, and therefore bring it back to center stage. Deepak, I'll turn to you. You're head of the Rotary Club Alliance for Leprosy Control. You must have been working in this area for a long time. What have you found are the main challenges in keeping this movement sustained, right? And
Right.
what is it that is required to keep that sustained effort? Because in communicable diseases, behavioral changes, as we all know, are the most difficult to influence. Unless you're at it all the time, then it kinds of rebounds and comes back again. Over to you, Deepak.
If you'll permit me, as a prelude to answering your question, let me just say that today COVID-19 has impacted the collective psyche of the world. It has completely altered our lifestyles. Before, leprosy was relegated to page 15 of the newspaper. It used to be considered the most horrific disease in the world. We don't want to scare people, but isn't it a travesty that just because in 2005, when it was declared to have been almost eliminated, even today, 165 people got harmed. Those are official figures. And as you know, as we all know from experience, that official figures tend to be a little understated. So the numbers could be a lot more. We've got to bring the focus back on leprosy. Now, as to your question, um, I have been fortunate to have been involved with Rotary International's fight against leprosy since the year 2001. It's been a long time. which proves the track record that Rotary is a marathon runner and not just a sprinter in a 100-yard race. We have more than 35,000 clubs all over the world in 220 countries with 1.3 million. What Rotary has managed to do with its partners, WHO, UNICEF, CDC, and the Government of India, in eradicating or getting rid of polio from India since 13th January 2011 can be summarized. I don't want to become too long winded, but it can be summarized under certain broad heads. First is direct funding. $2 billion US have been brought by Rotarians, fished out of their own pockets and brought into the program. I'm just trying to underline the potential. There is what Rotary has managed to do with ACRE in leprosy is leverage CSR funding, and there's a lot more coming on the way. But Rotary's role again in polio eradication, which has been sustained for so many years. Remember that the first NID in India was in the year 1995, and the one this year will be held on the 27th of February, and we are into 2022. So for 27 years, this has been going on, which perhaps directly addresses what you were saying, that you've got to have the stamina in such public health endeavors. Now, what this really required was advocacy. Without going into details, there's three kinds of advocacy. One was with political leadership, the second with the bureaucracy, and the third with religious leaders. Apart from advocacy, there was social mobilization on a very large scale to get people to accept the polio drops, to accept immunization. That is what we need to do with leprosy as well. The next was overcoming resistance. Now, there was a lot of religious resistance against administering polio. In this case, in the case of leprosy, as Dr. Chaudhary mentioned, you yourself mentioned, Shariq mentioned too, we need to get over the myths and stigma that has been attached with the entire disease process. Finally, it is partnerships, the power of partnerships, trying to meld all this. Again, as I said, WHO, UNICEF, CDC, to forge a partnership across the continents to address the disease. And we must remember that eventually you have to make it a people's movement where now, what is happening is exactly what was happening in polio, which is that there was unlimited supply of the vaccine. In this case, you have the multi drug therapy available from the government of India, free of cost, but there's just not enough demand. So it's a demand and supply gap working in the other manner. There's infinite supply, but just not enough demand. So we've got to make this a people's movement to generate demand. Sorry for going on for so long. You're muted
Thank
again.
you. Thank you. No, it brings a lot of perspective to the problem statement, as well as an insight as to the theme of changing people's behavior and attitudes seems to be the platform on which this rests. And honestly speaking, if you look at more, I can't say all of them, but a substantive number of medical conditions, whether it was diabetes, whether it was tuberculosis, in yesteryears, you would not say that anybody in your house had tuberculosis, or if there was a wedding in the family, you never wanted to say, oh, their diabetes runs in the family, or a cardiac condition runs in the family, uh, and so on and so forth. So social behavior is an exceedingly important element or thread to addressing these pieces. I'd like to now go to Mr. Prasant Naik, CEO of the Lepra Society. So, with you at the helm of affairs of the Lepra Society, right? You are interacting with the patients, you're interacting with society at large. You've seen this whole thing evolve. What do you think have been the biggest impediments towards eradication? And what is it, maybe crab like, which is pulling you down, other than the social aspect? Over to you. You're on mute, Mr. Naik. Yeah.
Okay, so am I audible now?
Yes. Yes, you're audible.
Yeah. So let me put a few things in perspective. Number one, leprosy or Hansen's disease, unlike other diseases, is completely painless. You don't feel the pain. So even if there are patches or nodules or wounds, you don't feel it. So by the time you really realize that there is something happening, and I go to doctor, and even doctors and the rural medical, the informal doctors or other one, whoever you, and if they are not equipped enough, they don't identify it as a leprosy in the first place. So it takes a long time, and by that time you probably have lost your nerve function. So leprosy, roughly, if you want to classify it, becomes a nerve disease where you lose the function of sensation, and then slowly leads towards initiation of disfigurement or disabilities at some stage later on, if not addressed. So the biggest impediments to control and eradicate this disease from India, at least, which has been there since the beginning of humankind, 6,000 years or even more, depending on how we classify, is, I feel, is the lack of prioritization. Once it was kind of said that we have eliminated, with the definition that we had at that time of World Health Organization, WHO, that less than one new case per 10,000 population in 2005. That was for the whole country, and we did achieve it, which is a proud moment for India. But there are huge tracts of geography within India which had more than one, even more than 5 prevalence new cases per 10,000 at that time, and kind of it was deprioritized. It became an integrated program, and it was difficult to sustain the momentum that we had gathered from last 20 years before 2005. Second one, I think, is the long incubation period. It takes from few months to many years, 20, 30 years, to really show its first symptoms. So you can have the bacteria within you and the symptoms will come out. So in 2005, when we had the cutoff of elimination, many people had and then it continued. And when it manifested many years down the line, and it has been spreading. And second is, it is considering the length of the incubation, a long gestation period for this bacteria, the cure, to a large extent, the multi-drug therapy, MDT, was found only in 1982. So considering the long incubation period, it's a very recent past. So we should not have rushed into saying that we have eliminated. We should have waited, and it's not late. We can continue and to bring it and refocus it. Then also, it's also non-prioritization by the person affected themselves. Self stigma is also there. The social things that we have already discussed. On the top of that, the lack of expertise, skills of the frontline workers even the medical workers, rural medical practitioners, the quacks and others, they don't recognize the symptoms and identify that this is leprosy. Let's detect it and cure it as soon as possible. Another one was it's a long medication like tuberculosis. So from around 6 months to 1 year, depending on where you are with the leprosy. So many times the patients don't adhere to the medication, because once the patch disappears and you have taken 1 or 2 months or 3 months of MDT, and then the capacity of the government, it's I think I personally feel we have come a long way. We have a long way to go, and currently the capacity is I would put it at very low end compared to other diseases within the government health systems. The and the long-term commitment is required for leprosy, unlike other diseases. We need to be there, as Deepak was saying, to be there for long term. There needs to be a strong surveillance of who is coming, identified very quickly, actively detecting the cases, and then administering the MDT and getting the person almost cured. And that will lead to some level of what do I say, control and eventual eradication. Eradication, I think, probably is a way forward, something to dream at this stage in my life. But we can control, and we should control. And over the last 2 years, as Deepak mentioned, alluded to it, COVID has come in, and suddenly the number of cases has reduced because we have not been able to identify and detect them. And then another thing is the awareness right from the primary level with the children to at the health professionals and others, and media can play a big role, and that's what we are doing now. So the awareness that this is a very extremely low infectious disease, bordering almost on non-communicable diseases. Few doses of MDT leads to the patient not being able to infect another one, and then the fact that it is there should not be any stigma, and it's like any other disease, and we are in the right track. I have to admit, India has come a long way. Now I don't see a lot of new people coming into the leprosy colonies. Whoever are there, they're there for last 30, 40, 20 years, and now people don't come into colonies. So because people have accepted that this is a disease which is curable, and it is cured after taking the diseases, and people go on with their normal life and they stay with their family, and that's a good thing, and we should build on that. And that's the way forward for India in terms of getting a control on this disease, and then eventually eradicating. Thank you.
Thank you very much for those insights, Mr. Naik. So what I'm hearing you say is that the story was good. We dismissed it far too early, given the fact that this has such a long incubation period. And I think the good news is that the stigmatization bit, that social stigmatization bit, and the ability to pick it up faster and thereby cure it, both of them have worked hand in glove to bring it kind of down. So there was one thing that you mentioned, which gives me a great segue to go back to Dr. Ritu. Dr. Ritu, what Mr. Naik mentioned was that the ability of the ASHA workers, the doctors, to be able to pick up cases, given the fact that the disease itself is such that it doesn't present itself, or it does not lend itself to being able to be picked up very fast. It's not that obvious. कि आपको दिखा खरोच है या आंख में जलन है, so you run to a doctor. So you let it incubate within your system till it comes to a point where it is moved a lot and the progression of the disease has gone way beyond what it should have. So from a perspective of where you're coming from, is there anything that can be done so that the screening programs or the sensitization, are there any capacity building initiatives? What in your mind is the best way to approach this?
Yes, ma'am. Under leprosy, National Leprosy Eradication Program, a few activities are initiated like active case detection and regular surveillance. This year, we have implemented this activity in Delhi also. In this activity, we enumerate the population, and here we train all our field level workers like ASHA workers and male volunteers regarding the leprosy and regarding the awareness of the leprosy as well as whom to suspect a case of leprosy. So we have trained a large number, around 4,000 ASHA workers and 2,500 male volunteers we have trained in Delhi on leprosy. And these field level workers will go house to house and do the active case search for the leprosy. And if they found any suspect in the area, they'll refer to the nearest health center where our medical officer will confirm the case. And if they confirm, they validate the case, and if they confirm the case, then we'll start the treatment. And this ASHA workers will ensure that the patient will complete the full course of MDT. So this initiative we have started this year in Delhi as well as in whole India. And active case surveillance we have Slack, which is our awareness program, Spurge leprosy awareness program, and we are also doing capacity building where we are doing training of medical officers, ANM, healthcare workers, field level workers, as well as our NLP staff. And we have done lots of training programs with the in collaboration with the ACRE, Rotary, and Lepra Society also. And we are doing awareness activities like health talks, oath ceremonies on the anti-leprosy days. So we are doing a lot of awareness activities as well as capacity building activities in Delhi. But lot more are required, like training of private practitioners, local RMPs also. Usually they are in the field, and first time जो patient हैं वो उन्हीं को contact करते हैं. So it's very important to involve these local practitioners also in the program, as well as we are not getting reports from the private sector. So there may be a large number of cases as we are projecting now, because we are getting reports from the public sector only. So I tried in Delhi to involve all private practitioners in the National Leprosy Eradication Program so that we can understand what is the actual status of the disease in the state, and how can we can do something better for the betterment of leprosy program, or in the direction of zero leprosy or zero disability or zero child case. So that is the situation of Delhi.
Great. So, one or two questions in what you said. And you said that the medication is free, and the first point of contact is the RMP, right? And it is not uh, is it mandatory for the private sector to inform you when they identify a patient? Is
No,
it
it
one
is
of
not,
those?
because this disease is not a notifiable disease. That is why the
Yeah,
private sector is not reporting such cases. But I have
yeah.
written lots of letters to our big hospitals of Delhi so that they'll start reporting, and we can extend our services to the private sector also. So that is our new plan, new initiative in the Delhi. But it's free. It's available free of cost, and we are supplying medicine to the private sector also, like Saint Stephen Hospital, which is a private hospital of Delhi. We are supplying free medication to that hospital. If the facility is reporting to us, we are providing them all medicine free of cost.
So, for instance, if there's an RMP who's identified a patient who's got this positive, right, and he says he's got himself tested and he's positive, how does he reach out to you to get the medication for his patient? Does he send the patient, or do you give him the medication? How does it work?
See, if actually this is not happening right now, anyways, अगर कोई भी हमें report करता है, तो we'll definitely register that case with us, and we'll provide the medicine to that facility also, or to that RMP also, because we are doing one more initiative in Delhi, that is we are linking all our patients, all our registered patients, to the ASHA workers, and we are trying to link them so that all patients who are registered should complete their treatment. So we are not only this कि Asha will bring the patient to us. We are also linking the registered cases to the Asha workers so that we can ensure the complete treatment of the patient. So if a RMP reporters will also do the same thing with that case also, because it will help us in further contact tracing, contact family examination, contact tracing, as well as awareness in the community. This will definitely help us.
Hmm. So the pivot in this entire piece is the ASHA worker. That's what I'm hearing you. Whether it is identification, bringing the patient to be able to get tested, whether getting the medication, everything is to the ASHA worker. So would it make sense? And I think I move to Deepak with this question. Deepak, would it make sense to incentivize? So at the end of the day, an ASHA worker is an incentivized provider, right? And therefore, if there is no incentive which is associated with this, uh, will it be able to have that kind of traction? Is where I'm coming
It's a great question, and I think you're actually cutting to the heart of the matter. The challenge is, how do you incentivize an ASHA worker? Now, every ASHA worker has this entire menu of opportunities, or if you sort of be a little facetious and compare it to a restaurant, she's got a lot of choice on her menu. It could be tuberculosis, it could be diphtheria, it could be heart disease, it could be pregnancy, it could be a whole host of diseases, and leprosy is only one of them. Now, we obviously need the permission of the government, the state government, the central government. You know that the health is on the concurrent list. So both
from.
the central government and the state government are involved in it. The implementation is done by the state government. So now we have to have the permission of the concerned state government before we can consider any monetary benefits to ASHA workers.
Hmm.
A possible alternative could be what Rotary has utilized in the past, is to have a system for vocational awards. Just recognition. You're not exactly incentivizing them. So if you go go back to Maslow, you are addressing the self-actualization or the recognition need rather than the basic physiological need. Eventually, money makes the mayor go. And if the state government and voluntary organizations can come together and have an incentive scheme, basically, it's a difficult question because to pinpoint only leprosy would be a challenge. The
Yeah.
second point, very quickly, which I wanted to make was that the ASHA worker, as you rightly said, is the pivot. But we have to remember that leprosy strikes the rich as well.
Hmm.
Now, I heard this from Prashant, the famous actress, which in your and my day, I mean, she was really famous, Dimple Kapadia, contracted leprosy before she acted in Bobby. And because it had been identified early enough, she was treated and is fine. So the point I'm trying to make is that we need a system in the private sector as well. Tomorrow, if I contract leprosy and somebody gives me the address of an ASHA worker, I may not want to go there. But if it were a private practitioner with whom I'm comfortable, be it a hospital like Max or Apollo or whatever, um, it would make sense. So we've got to rope in the private hospitals, not just the private practitioners, but the bigger hospitals also to voluntarily report whenever they get patients who appear to have the symptoms of leprosy.
Right. So, Mr. Naik, I'll come to you on this. You've been with the mission for a fairly long time. 20 years is a long time to be with them. Uh, what do you feel is the impediment as far as the larger hospitals is concerned? Right? Why are they so resistant, or why is there this uh, inability to be able to be participative in managing this, right? And
Yeah.
the sense and feel I get is there will be, and I think Dr. Ritu also alluded to it, the concept of underreporting will be there because they don't come. It's not a notifiable disease, so you really don't know the actual numbers. I think you also mentioned that. So, what is this pushback from the hospital perspective? Social, I can understand. But from a hospital or an RMP perspective, why is there this pushback?
Yeah, this is very important, and this is something we have to, as I mentioned in the previous impediments. One of the important thing is both at the RMP, private practitioners, or even the top end of the hospitals, the skills have disappeared, and it's a diminishing tribe. The people, the doctor, the workers who can identify leprosy are very limited. You can count them. Even in my organization, the numbers are decreasing. It's very difficult to find. And for example, I will just say one is a physiotherapy, a normal physiotherapy, and a leprosy physiotherapist. It's very different. Even at a general physiotherapist can do harm to a leprosy patient in terms of providing physiotherapy services. So those skills are first disappeared. And it's not being taught in the medical schools. Second, as Deepak was saying, and Ritu ma'am said, and you also said, it's about money. Leprosy with the less numbers and mortality rate being almost non-existent because you contacted the disease, there is no money in this. And a lot of, fortunately, unfortunately, whatever you want to say, a lot of our private sector doctors and medical professionals are motivated by returns. It's a profit loss kind of things. Service is the important part, it's not there. And the third, which I feel is the most important also, is again, it's related to social, but it's my self stigma and discrimination. Even if I know, I don't want my doctor, my hospital, my to pass it without my permission. So there is a self censorization. I don't want it to be reported for whatever reasons. Maybe I feel I have family pressures. I don't want my family members to know, or there is social pressures within the larger family or community. So the three aspects: lack of skills, lack of money in that, which is very blunt to say, and the third is self censorship leads to a situation where it's limiting. And this is true both in Asa's case at the right at the bottom of the front line village level worker at the far hard to reach area, and also at the top level in the Apollo or Max hospital.
Right.
Yeah.
Right. So that brings me to the one person who is exceedingly important, or the concept of that person is exceedingly important, and the person who's behind the money. So, back to you, Shariq. How do we get this show on the road? So, money is needed because if you don't have that money to be able to get this train on the wheels, so that sensitization, awareness, because these seem to be the building blocks which will then make it happen. So, awareness of people, sensitizing not only communities, But it's very clear that the medical community also, the healthcare delivery system also needs to be re-energized, because without the two happening, the ultimate goal will not be there. And lastly, though I think that piece will be a little easier, and here maybe Ritu at a later point when we are doing our closing remarks can come in. Capacity building, training, that's something that the government does very well. They constantly training their workforce, and to a certain extent the private sector also. But awareness campaigns, building up the rhetoric on this can only happen through CSR funding.
You're absolutely right. When we actually initiated this entire project, the basic three objectives of this leprosy control project, by the Rotary Club was, number one was the awareness, which includes basically not only the awareness among the public at large, but also it includes the training of the ASHA workers and the health professionals. And basically it also we also required a lot of awareness program to be run in this entire project, because we want to attract the attention of the decision makers also, people who are behind making policies on the healthcare sector and all, or that attraction is also required to be taken. So awareness is, yes, is the most important objective of this entire project. The second one was, the treatment part, wherein we are providing customized shoes and physiotherapies to these patients and all, which also requires a lot of to hold various health camps, wherein these patients are invited, and we achieve both the objective of creating awareness and providing them all the medical help which they require from our side. The third one was the basically the rehabilitation of all these people. Now, as you are aware, there are I think more than seven colonies in Delhi itself, wherein they are basically where all these patients are living with their own families. And we are aware that this the social stigma which is attached with this disease has caused so much harm to these people, because people are actually kicked off from their families, I must say. They are not even people are not even nobody wants to talk to them, nobody wants to come in contact with them. But so these people are actually cornered to various specific colonies of leprosy patients. But we were being told by this Rotary that they also have their basic needs, like since last year we have actually covered 2 3 colonies wherein we have provided all these solar panels, so that they can the electricity problem of these colonies can be solved. All these things, as a whole, requires money, as you rightly mentioned. And to be candid, initially when we started this project, I remember when I had a word with Mr. Deepak Kapur also and the entire Rotary people, and we were having a concern that nobody wants to contribute towards awareness side. People want to put their money into healthcare, like to providing all the medical facilities, putting in solar panels and all these things under CSR, I'm saying. But people don't want to put their major part of the funding towards awareness. But over the period we realized that this is something which is required, and when we realize that nobody else is going to put in money herein, so as a CSR partner, it's my moral responsibility to support this fundamental objective of creating awareness among the society. And let me tell you, since last year, despite this COVID situation, we are doing very good. I mean, I appreciate the efforts of Rotary Club and Lepra, who have actually done a great job in the society. And today, as part of that awareness only, we are all together, sitting here and talking and discussing this thing. I'm sure this is going to create a lot of buzz in the society and is going to help these people. But funding, yes, you're absolutely right. A lot of funding is required, and Acre is a one of the CSR partner in this project. Always like to attract other corporates also who can participate in this, because see, everybody has their limitations. And I just like to conclude here with just a small Urdu couplet, if you allow. This that मेरे अपने चिराग में तेल की कमी बेशक है. अदना means small. तो मेरे अदने चिराग में तेल की कमी बेशक है. जितना जितना बन पड़ेगा रोशनी फैलाता रहूंगा. Thanks.
Thank you. Thank you very much. So I'll just circle around. I think we've got 9 minutes left for the last concluding remarks. So Ritu, you've heard what Shariq, Deepak, Mr. Naik have said. In a perfect world, if you were to reach out to the CSR community, right? Based upon your experience in working here, what are the top 2 things you'd ask them to do for you?
As Shariq sir said, first foremost, one thing which is most important is the awareness part. We need to aware not only the community but also the medical fraternity, because people tend to forget this leprosy and they said कि अभी भी है leprosy, अभी भी है. सो अगर कोई ऐसे सोचता है कि लेप्रेसी अभी भी है, तो दे विल नॉट गोइंग टू सस्पेक्ट एंड दे विल नॉट डायग्नोज दैट डिजीज. So it's very important. First is the awareness, and then second is the capacity building. We need to train all our healthcare care workers, field level workers, local practitioner, as well as the medical fraternity at medical college level. So we need to train each and every person. And so these are my two important field. One is the awareness and second is the capacity building. And if you allow the third one also, that is the active case search, because active case search plays a very important role, will play a very important role in the eradication of the disease.
So if I hold you to the word capacity building, now in capacity building, are we looking at specialized nurses? I don't think it will warrant specialized nurses. What would you classify as capacity building or
Actually,
human resource?
leprosy is a very simple disease. No special
Correct.
equipment is required for the diagnosis of leprosy. Just on the basis of clinical examination, you can diagnose the disease. Still, there are lots of hidden cases or misdiagnosed cases. So it does not require any specialization. It does not require any special investigation. Only on the basis of clinical examination, we can diagnose this patient and we can provide them a complete treatment which is free of cost. So it is a very simple disease to treat or to prevent from complication, but still it's existing. We have मैं ये नहीं बोल सकती कि अभी तक हमने कुछ नहीं किया है, हमने बहुत कुछ किया है एंड वी लैक्स से अब हम थाउजेंड्स में आ गए हैं. तो इफ यू वांट टू इरेडिकेट द डिजीज, वो जितने भी एफर्ट्स हमने अभी तक किए हैं, वी हैव टू कंटिन्यू देम इन अ वेरी न्यू स्ट्रैटेजिक वे.
Right. So reiteration while they're in training, reiteration on the shop floor, that has to continue so that it doesn't move out. Deepak, what would your top 2 items be? You're on mute.
Yeah, I'll try and put them into one,
Okay.
which is that right now we are talking about spotting leprosy cases, finding new people who've got leprosy. But let us not forget the cohort that we have built up over the years. What are we doing for them? We are making an attempt with ACRE, as Shariq said, to give free food for months. And that was also another, not an ACRE, but another CSR grant for the marginalized people in the leprosy colonies. I don't know how many of our people who are viewing this would be aware that a place called Tahirpur in Delhi has more than 29 colonies. Am I right, Prashant? 29 colonies in just that Tahirpur, where only patients of leprosy live. Now, Despite our best intentions, what we are doing is providing them fish for a day. We've got to teach them how to fish, the old adage. Jobs, we've got to try and find jobs for people. People become non transmitters a mere 72 hours after taking the MDT or the multi drug therapy. We've got to find them jobs, which is not going to be that easy. So, if we can't find them jobs, we've got to equip them to to start small cottage industries or equip them with skills. Work from home is today um, the, 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 the most used phrase today. So maybe these people can be imparted computer skills, basic typing, composition, transcription, where they will not really have to come face to face with the people that they are serving, desktop publishing, stuff like that. So, the point I'm trying to make is we've got to equip them to be able to make a living for themselves.
Yeah. So it's kind of mainstreaming them to be able to be, as you rightly pointed out, teaching them how to fish. Mr. Naik, your concluding comments, please.
Thank you, Dr. Shubnum. So, as I was us, and there are two things, as you said, very important. One is, I would say, uh, replenishing the diminishing capacity in terms of skills of leprosy personnel or professionals, both right from the doctor to the physiotherapist, also treasures to the frontline workers. The other one is research. You know, there is a lot of gap in this. As Dr. Ritu said, it's a very simple disease, but still we haven't figured out the exact mode of transmission. Of course, it's believed strongly that it's transmitted through droplets in the air, but there is still there is no conclusive research saying that these are the only modes of transmission. The other thing which I will strongly support is Deepak, what he's saying about providing providing dignity, a dignified livelihood, where they don't get, corporates can employ them after getting sufficient training and all. That will go a long way. Second, they can have their own enterprises and they employ others who are not infected or affected by Hansen disease, by leprosy. So it brings in a very good integration. And this I am saying, I have seen it in one of the diseases, one of the colonies called the Jyoti leprosy colony, which coincidentally has a big mango farm of about 200 acres. And people from the nearby villages come and work there. The leprosy owner, which is a collective, they employ the people from around the village. And it's a very good integration. And that's the way forward. And we need to look at it, how we take it. And if we allow me, please, this is sorry to taking incentivize the workers like we did in Basant Row, which was disease. We paid a lot of money for identification. If we really pay about 3,000, 5,000, even 10,000 to ASA workers to identify a suspect, it will we will really move forward with a lot of active case detection, because the numbers, as Dr. Ritu was saying, is in thousands. So if there will be a huge momentum towards finding the at very early stages, so saving the lives of the young girls, young boys and people, and then they have a normal life because it's curable. So, and it will not cost us more than 1,000 or 1,500 crores a year maximum. And government of India is spending a lot of money, and this is peanuts compared to what we can achieve with incentivizing the frontline workers by paying even 5,000, 10,000 rupees for identifying a new suspect for active case detection. Thank you, Dr. Sam.
Thank you, and bang on time. I like the way you said it's a very small amount, but when you speak to the government, every penny counts. But thank you so much. You've been a great panel, and we've kept to time. And hopefully, when we meet again, Dr. Ritu can share better numbers with us, and we can feel that this was well worth an hour. Thank you very much.
Thank
Over
you.
to
Thank you.
you.
Thank you.